its professional literature. The golden rule of PFA is placing the welfare of patients above personal aims and desires. PFA also works to encourage students and senior dentists through annual awards and foster advancing their scientific and professional standards. PFA International Office gives 1 Best Student Merit Award and 15 other Best Student Awards. And PFA India section gives 14 Best Outgoing Student Awards from 14 different dental colleges of India. Fellowship in PFA is by invitation or by nomination only and is limited to ethical dentists. Professional leaders select fellows based on contributions to dental literature, service to the profession of dentistry, and service to the general community. The PFA India section mentorship program for BDS graduates is an innovative initiative, and we have mentorship programs in oral and maxillofacial surgery conducted by Dr. Varun Menon, and in conservative dentistry and endodontics conducted by Dr. S. Balagopal. The PFA mentorship program is held virtually, and the students are selected from PFA awardees. The program is for 3 months, and successful trainees will get a certificate. The Journal of PIERRE Academy is an official peer-reviewed journal of PIERRE Academy India section, and the journal publishes original and basic research articles, short communications, and case reports. Professor Dr. O.P. Karbanda is the present chief editor of the journal. We welcome you to the prestigious PIERRE Academy Fellowship through PIERRE Academy India section. I recognize the presence of senior PFA fellows of India section. I request the fellows to stand so that the students can give flowers to you. I welcome Emeritus Secretary PFA India section, Dr. T. Samraj. Along with that, I recognize the presence of Director from VMRFDU, Professor Dr. B. Jayakar. I welcome Senior Orthodontist and International Speaker and Senior Orthodontist, Professor Dr. Vadivel Kumar Sir. Senior Practitioner and Chairman, Madam Chairman, PFA India Section, Dr. Vinita Chugh. Treasurer, PFA India Section and Senior Oral Surgeon, Dr. Arun Kumar. Director, Alumni Relations, VMRFDU, Dr. Ramesh K. Director, School of Allied Health Sciences, Dr. Kamraj. Professor from the Department of Prosthodontics, Dr. Bindu. Professor from Annapurna Medical College, Dr. Vasandan. Oral pathologist and researcher from RAK College of Dental Sciences, UAE. Senior dental practitioner from Kerala, Dr. Jaya Reddy. Thank you very much, and Jai Hind.
Thank you, ma'am, for your informative words. I now invite our Dean, VMSDC, Professor Dr. J. Baby John, to deliver the Dean's address. Welcome, sir.
Very good morning to you all. Respected Chief Guest of the Day, Professor Dr. Sabarinathan, the Pro-Vice Chancellor of VMRFDU, the Chairman of PIERRE Academy, Professor Dr. Rajiv Kumar Chugh, the Secretary, Dr. Maya, the Organizing Chairman, Dr. Sai Ganesh, the Organizing Secretary, Dr. Diana, the key resource persons of the day, Professor Dr. Padmanabhan and Dr. Sharat Ashokan, the fellow members, the officers and the directors from the university, the postgrads, the interns, and my dear students. At this outset, I'm really happy to be here on this midterm convention of PIERRE FAUCHARD Academy India section. This is something which we had been bestowed upon to us a year back, and we owe our gratitude to the office of the PIERRE FAUCHARD Academy for entrusting us with this responsibility to convene this midterm convention. The purpose, basically, you will be coming to know through our chairperson what exactly the PIERRE FAUCHARD Academy is. Basically, in a single word, I would say it's a leadership summit where they develop leaders and safeguard our professional integrity and propagate our skills and knowledge among our people as well as the public. Basically, you can see this PIERRE FAUCHARD Academy composes of various eminent personalities who have contributed for our profession. And you can see the senior most doyen sitting down, Professor Dr. Samraj and Dr. Chug and all others, Dr. Regd and others. And we were all the next line generations from 2009 onwards. So that's how it is being groomed up. And it is an international society. Having said that, the idea of today's convention is mainly to bring up the leadership spirit as well as the research knowledge amongst the coming up professionals. As it was done last week, it was an online program for the scientific session. It was a wonderful session which was conducted very meticulously by our scientific chairperson. And more than 50 colleges across India had taken part in this online scientific paper and poster presentation, for which I have to really get a good applause for the organizing team for taking a well-planned effort to bring in various colleges, thereby get to know what PIERRE FAUCHARD is doing to the society. And today is the day again. We have got two experts in our own field, Professor Dr. Padmanabhan, who is a renowned personality in the specialty of prosthodontics, and Professor Dr. Sharath Ashokan, who is also a renowned personality in pediatric dentistry. So they are going to deliver the lecture which will cater to your level of understanding. The international figures over here and the guests over here are here to encourage the youngsters who have come from various colleges physically, for which I will have to acknowledge that you have taken the time, and the leaders or the deans of the colleges who have cooperated for our invitation and bringing you here this morning. I'm sure today's deliberation will give you an insight about what PIERRE FAUCHARD Academy, what research, what leadership is. And I'm sure today's event will be very memorable and very useful. Thank you so much.
Thank you, sir, for your visionary and encouraging words. I would like to invite Chairman, PFA India Section, Senior Member of Dental Council of India since 2025, and President of IDA, National Head Office 2023 to 2024, Professor Dr. Rajiv Kumar Chug, to address the gathering. Welcome, sir.
Good morning, everyone. Chief guest of today's function, Dr. J. Sabrinathan, Pro Vice Chancellor, Vinayaka Mission Research Foundation. Dr. J. Baby John, Dean, Vinayaka Mission, Sankarachariyar Dental College. Organizing Chairman, Dr. N. Sai Ganesh. Organizing Secretary, Dr. Diana Prem. Dr. T. Samraj, Secretary Emeritus, PFA India Section. Dr. Maya Ramesh, Secretary, PFA India Section. Dignitaries on the dais and off the dais, Dr. G. Rajkumar, the office bearer from IDA Tamil Nadu branch. Eminent speakers, Dr. T.V. Padmanabhan and Dr. Sharath Ashokan. Faculty members, IDA members, PFA fellows, and my dear students. I, on behalf of the PIERRE FAUCHARD Academy, its Senate and Fellows, welcome you all to this Midyear PFA National Convention 2025, which is being hosted here in this premium institution of the country today. I am grateful to Dr. J. Sabrinathan and Dr. J. Baby John and the organizing team for their dedication, commitment, and hard work in putting up such a splendid event. I understand all of you, along with our dynamic secretary, Dr. Maya, have devoted lots of time to go through the minute details of conducting this paper and poster presentation, which has been in progress for the last few weeks. Dr. Baby John, I compliment you for your superb leadership. The students from many institutions from this region have participated in this competition. I thank you all for your contribution in the success of this program. As you have already been told, that the PIERRE FAUCHARD Academy globally is an honorary dental service organization that was founded in 1936 with a prime concern for the search of knowledge and raising of professional standards. The main objective of PFA focuses on integrity and ethics. Our mission as fellows in the PIERRE FAUCHARD Academy is to recognize and develop outstanding leadership in our profession, focusing on professionalism, integrity, and ethics. The values inculcated as a fellow is to conduct oneself as worthy role models by the advancement of dentistry to the highest level, by supporting and honoring colleagues for their distinguished work, research, contributions, and public service, and by providing excellence in programs, education, and leadership in oral health care. The PFA India section was installed during the Golden Jubilee of PIERRE FAUCHARD Academy. The global Academy was celebrating 50 years in 1986, and at that time, under the most able leadership of Dr. T. Samraj as chairman, and many more stalwarts of dental profession in India like Dr. S.S. Sidhu and Dr. V.P. Jalili, to name a few, this section was initiated in 1986. We are truly blessed that the founder of the PFA India section, Dr. T. Samraj, is present amongst us here in the audience today. I request all of you to rise and giving a standing ovation to Dr. Samraj sir. He has been the pillar of strength and guiding force to the organization. Dr. Samraj has contributed immensely not only in the PFA India section, but also to the Indian Dental Association and the Indian Orthodontic Society. I congratulate and thank Dr. Samraj for his immense commitment to the dental profession in the country. The most outstanding feature of PFA has been that the Journal of PIERRE FAUCHARD Academy was also started simultaneously in 1986 and is still being published regularly. The well-acclaimed journal for the last 7 years is now being published by eminent academician and clinician Dr. O.P. Kharbanda. I request all of you to please contribute your scholarly work in the Journal of PIERRE FAUCHARD Academy, which is now in its 39th volume. The journal is indexed with G-Gate Plus and Google Scholar and is now open access, free online with no publication charges. The journal editorial team processes the decisions very quickly, follows the quality control, and even supports novice contributors to optimize the work to bring it to its high quality. We are releasing today a special issue of the journal for all of you to have a look at the efforts being put in by the editorial team to elevate the journal further to greater heights. I also take this opportunity to thank my Senate members, especially Dr. Maya Ramesh, our extremely hardworking secretary, and our co-chairman, the chief guest of today, Dr. Sabrinathan, for standing by me and supporting me in all the activities I keep planning and keep Dr. Maya on her toes all the time. Maya, I am grateful that you have not complained so far. Respected Dr. Sabrinathan is a very low-profile, silent, and motivational worker in the Senate of PFA India section. You truly inspire us. Dear colleagues, the fellowship to the Academy is by nomination. the honor of fellowship is conferred on those dentists who have demonstrated they have served and or have great potential of service and leadership. The India section has amongst its ranks fellows who are outstanding dental researchers and teachers and have had continuing role in fostering dental science. I can see among the audience a lot of young oral health professionals who are going to carry the flag of the dental profession high in the coming years. You are our future fellows, our future leaders. I wish each and every one of you a very bright future. May you excel in the profession, and I pray that God blesses you all. Thank you so much. Jai Hind.
I recognize the presence of Head of the Department of Oral Medicine and a Senior Fellow, Dr. Ramachandra Reddy. I request the students to give a flower. Two flowers. Take 2 flowers. And I recognize the presence of Secretary IDA and our Senior Fellow and orthodontist, Dr. Sendamarai Kannan. Thank you for coming. Please give one flower to Sir also, Oral Medicine HOD. Thank you, sir.
Thank you, sir, for your valuable words. Now is the most enlightening moment. We are pleased to announce the release of second issue of Journal of FAUCHARD Academy, which includes 77 scientific abstracts presented during this Mid-Year National Convention 2025, along with the other regular articles. I request our chief guest, along with the other dignitaries, to release the journal. Thank you. I would now like to invite our chief guest, Pro Vice Chancellor, VMRFDU, Professor Dr. J. Sabarinathan, to address the gathering. Welcome, sir.
Very good morning to all of you. Respected Chairman of PIERRE FAUCHARD Academy, India Section, Dr. Rajiv Kumar Chugh, the Dean of VMS Dental College, Dr. Baby John, the Secretary PFA India Section, Dr. Maya Ramesh, the Organizing Chairman, Dr. Sai Ganesh, Organizing Secretary, Dr. Diana, the resource persons for today, Dr. Padmanabhan, Dr. Sharath Ashokan, the Emeritus Secretary, Dr. Samraj, senior members of the PIERRE FAUCHARD Academy, India Section, senior officers of the University and VMS Dental College, faculty members, invited guests, and dear students. It is indeed my pleasure and honor to be here for the inaugural session of the PIERRE FAUCHARD Academy India Section's Mid-Year National Convention. And I really thank the PFA India Section and Dr. Raju Chugh for awarding us to our organization, the VMS Dental College, to host this program this year. And it is particularly special because as we celebrate our silver jubilee of the establishment of our university, the Vinayaka Mission Research Foundation University. We have always been associated with PIERRE FAUCHARD Academy in the past as well. I do remember we organized a practice management symposium or a convention in the year 2016, thanks to Dr. Samraj, who was the secretary at that time. And just like that mega event, this I believe is also very, very successful with more than 500 participants, which is 2 days online program and 1 face-to-face program. Again, as always, VMS DC is good in organizing events, and they have proven it one more time. I'm glad to see there are a lot of students in this arena. Dentistry as a profession, or any other profession, is moving more towards industry focused and also moving more towards the multidisciplinary approach. When you students graduate, you would see that kind of a trend in your profession as well. The practice is more patient-centric. Of course, in a way, it is more like a consumer-centric, but we can call it as a patient-centric, where their preferences and desire also have to be taken into account. When a patient comes to your office, they are very much knowledgeable about the treatment, what they want to seek from you. It is there. Of course, they get it from various ways and methods, but it is there, which you cannot deny that. The fact that clear aligners is one example where the patient-centric approach has revolutionized our field. Most of you are not aware that the clear aligners was not invented by a dentist, but by a patient. So that is a proof that we are moving more towards the patient-centric, and you must be aware about it, and you must be more pragmatic about it and not dogmatic about it. And also, you can't be very isolated, you can't be very exclusive as a dentist-only profession here. You must learn to work with the other fields, not necessarily in dentistry, but also in the field of medicine, or for that matter, in the field of engineering, technology, even in finance management. It is inevitable, and that is the only way you can guarantee your success in your near future. And these attributes simply cannot come once you graduate. It comes through good practices. As an institutions, we do our best, despite the fact that we have a very structured curricular framework. We tend to give you more knowledge in other areas in whichever time we find. But again, that alone is not enough. You may have to seek the knowledge as well, and there are many ways to it. To start with, you must be associated with the associations, like whether it is PIERRE Fortune Academy or Indian Dental Association, or your own specialty organization like Indian Orthodontic Society. That is one good step which you may have to do it, and I'm glad that you all are so keen to come and participate in this PFA event. And as the Secretary and President have said, they have already listed out what are the advantages of PIERRE Fortune Academy, being associated with the PIERRE Fortune Academy, and expect you all to do the same once you become the graduates. Today we have 2 exemplary speakers who needs no introduction, Dr. T.V. Padmanabhan and Dr. Sharad Ashokan. In fact, I could fondly remember when I was an intern in the 90s, I attended Dr. Padmanabhan's lecture. It's good to see him here again. And he has been associated with the PIERRE Fortune Academy as well. In 2 years before there is a media convention, he was a guest speaker, and he is a fellow as well. Again, welcome you, Dr. Padmanabhan. And Dr. Sharad Ashokan, he's been associated with our organization. He was a former member of our Board of Studies of VMRF deemed to be University's Faculty of Dentistry. It's good to have him here as well. And I'm sure this convention would be thoroughly enjoyable and informative for all of you. I wish you all the very best. Thank you.
Thank you, sir, for your inspiring words. I now request our Dean, Professor Dr. J. Baby John, and Organizing Chairman, Professor Dr. Sai Ganesh, to felicitate our guest and speaker as a token of our appreciation for their presence and contribution to this event. To the Chief Guest, Pro Vice Chancellor, VMRFDU, Professor Dr. J. Sabarinathan. PFA Chairman, Professor Dr. Rajiv Kumar Chugh. PFA Secretary, Professor Dr. Maya Ramesh. And our keynote speakers for the day, Professor Dr. T.V. Padmanabhan, Professor Dr. Sarath Ashokan. Thank you. Now we move to the much awaited keynote lectures of the day. I request the other dignitaries on the dais to kindly take their seats off the dais and join the audience as we begin the session. I take great pleasure in welcoming our distinguished first keynote speaker, Professor Dr. T.V. Padmanabhan, on the topic Care of Stomatognatic System for Overall Well-being of the Aged Population. Welcome, sir. I request Dr. K. Ramesh, sir, Director, Alumni and Placement Relation, VMRFDU, to kindly chair the session. And I request Dr. K. Ramesh, sir, to kindly introduce our keynote speaker to the gathering.
Password Srihari, SRI. Sorry. SRI, HARI. Kamal. Okay. என்ன பண்ணுங்க எல்லாம் ஃபாண்ட்ல சின்னதாயிடுச்சு. சரி என்ன பண்ணுங்க ஓப்பன் பண்ணட்டுமா அடே அப்பா ஆஹா ஒரே ஒரு நிமிஷம் சேலம் ஜீரியாட்ரிக் சேலம் ஜீரியாட்ரிக் கண்டினியூ போட்டுமா இது தம்பி கீபோர்ட் செட்டப் அசிஸ்டன்ட்னு போட்டுக்குது சார் கண்டினியூ போட்டுமா ஐடென்டிஃபைங் கீபோர்ட் ஆன் பண்ணிட்டீங்களா சார் இப்போ பிபிடி ஓப்பன் பண்ணட்டுமா ஜீரியாட்ரிக் சேலம் என்னது கரெக்டாக சொல்லுங்கள். முன்னாடி பின்னாடி அம்மா பாயிண்ட்ரு
சரி இது
ஃப்ரண்ட் பாயிண்ட்ரா
பாயிண்ட்
அதுவா இதுவா ஓகே ஃபைன். இதுதான் தான் பாயிண்ட்ரு. எனக்கு மேலே இருக்கிற நீ ஒரு வீடியோ ஒர்க் ஆகுதான்னு பார்க்க முடியுமா? வேணாம் இல்லை, அது ஸ்க்ரீன் ஓப்பன் ஆகிடுச்சு.
செக் பண்ணிக்கிறேன்.
என்னது
வீடியோ
சரி வேணாம், ஒரு வீடியோ வராங்கட்டி போகுது. என்ன பெரிய கஷ்டம், ஒன்றும் கஷ்டம். ஆமாங்கய்யா, ஆமாம்மா.
Very good morning. A very good morning to one and all who are present here. We start the scientific session with the first keynote speaker. I would like to introduce Professor Dr. T.V. Padmanabhan. He is a senior prosthodontist with over 3 decades of academic and clinical experience, a graduate and a postgraduate from the Tamil Nadu Government Dental College, Chennai. He has served in various key positions in academic positions as well as in the society across major institutions. He was heading the Department of Prosthodontics at Sri Ramachandra Dental College from 2004 to 2016, and he has guided several PhD scholars. He is widely known for his textbook of prosthodontics, which was released in the year 2013, and he has contributions to multiple textbooks, and to name few, he has a textbook on indirect restorations. He has published over 82 articles in index journals, and he has served as a course writer in implantology for IGNOU. His leadership roles, I would like to name few of them. He is the president of Indian Prosthodontic Society, co-president of the Asian Academy of Osseointegration, chairman of Indian Board of Prosthodontics, secretary of Asian Board of Prosthodontics, affiliated member of ISMR USA, and a diplomat of International College of Oral Implantologists. His international achievements including his visiting NUH Singapore for training and understanding educational system. He received the Japan Dental Association Scholarship and Professor Kim Award for the best poster in Asian Academy of Prosthodontics meet at Thailand. Dr. Padmanabhan continues to contribute to the advancement of prosthodontics across India and Asia, and it's my proud privilege to welcome to this forum, sir. The stage is all yours. Welcome, sir.
Chairman, sir, for the excellent introduction, and my respects to all people here, and very warm welcome to the chairman, Professor Chuk. Welcome again to Tamil Nadu, sir. We are always warm. And my respects to all the students and the prosthodontists, postgraduates. Maybe it is a very, age-related topic that I'm going to be talking. And let's see how interesting it's going to be. If it is very boring, you can sleep. There's no problem at all. And at the outset, I would like to thank the PIERRE FAUCHARD Academy as well as Vinayaka Machine for giving this opportunity. And it is my greatest privilege to come here and then lecture on this topic. We have seen him yesterday. We are seeing him today like this, and then we'll very soon see him like this also. What does it mean? It basically means that we are all getting old, simple as that. And most often, their oral conditions will be something like this, with a very few set of teeth, and even then, the rest of the teeth remaining will be so very badly, broken down, which are most often non-functional. So what could be the treatment options for all these people? And as usual, go for an implant, do a good full mouth rehabilitation with an implant, or use the existing teeth and then go for a fixed prosthesis and make the patient very happy, or remove the unwanted teeth, go for some overdentures, or you can even think in terms of a complete removal of all the teeth and go for a complete removable set of teeth. So you have a full gamut of treatment, right from implants, fixed partials, removable partials, as well as your complete dentures. The question is, which of these will be successful? When you talk about success, 30 age, like the age group 30, the patients, the only requirement for them is aesthetics. They want to look good. Function is okay, they can get a compromise on function, but the most important thing, they want to look good. At the age of, say, 50, success at 50, not 60, pain-free and easy hygiene. The most important thing beyond 60 is that they must have a good quality of life and without any pain. So what is the concern for us? My concern at least is about the people above 60. Okay. அப்ப இது கொஞ்சம் தள்ளி போட்டலாமா? முட்டுது. Okay. All right, good. I'm still fit. So what is the recipe for success for all these people? The recipe for success is careful. Okay. So I have been teaching for quite some time. I don't need a mic, but anyway, now that it's been given, might as well use it. So I have to select the case properly and then write diagnosis and treatment planning and design simplicity. I'm talking about people who are about 60. The worst thing of late, the dentists who are coming into the profession, is that they have a standard protocol. The patient comes, whether he is 5, 50 or 15 or whatever be the, just give them the smile design. There is no need at all. My concern is that all the people need not have to have a good smile. The most important thing is that when you do the treatment according to the age. So the recipe of success is long-term pain-free function in patients with this particular age group. Okay. And what happens? After a very successful treatment, yes, they are very, very happy for the rest of the life. Is this the end of the treatment? No, unfortunately, it is not the end of the treatment. Certainly not the end of the treatment, or it is just the beginning. What happens after a happy institution of a denture or a prosthesis? They are not able to maintain. Old age strikes in, and what happens is you welcome the real world. In the sense, the real problem starts only from here. How successful are our complicated and heroic treatment, and what is their long-term success? They are successful from the patient point of view. Whether it is successful or not is the most important thing. How many of us do a good class 1 or class 2 cavity preparations and then give a filling? At the end of the day, you see your filling, and what is the first thing that you tell for yourself? Yes, I have done a good job. I am very happy about what I have done, because you are dedicated. How many of us care to ask the patient, how comfortable are you? You don't have any yardstick for assessment of the treatment that you have rendered. Whether it has gone to the patient, whether the patient is wearing it, or whether the patient is going to be using the denture, how useful is your treatment? There is no assessment yardstick, unfortunately, in our system. But anyway, these will slowly come in. So I'm going to be talking about the care of stomatognathing system for overall well-being of the aged populations. So what is the need for us to discuss? The need for the discussion is very, 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 very evident, because the old age population is increasing. An adult is defined as an elderly based most often on his age, his ability to travel, and his ability to seek his services all by himself. Very, very interestingly, down the line in 2050, every third person or every fourth person will be 65 plus. So you must be ready to work. Now you will be seeing more of this gray-haired people roaming around in the town or lying down in the bed, and you should be ready to work for them. Statistics globally in 2009 is very, 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 very less amount of about 9% of the population. But if you're going to see 2050, it is going to be easily about 25 to 29, that is every fourth person, every third person will be 65 plus, with or without the teeth. The people without the teeth, boon for us, because you will be able to make a lot of money, number one. Number two is you will be able to give a good service. The most important thing is you're able to give a good quality of life. So a situation worldwide, What is happening? Why is that there is going to be such a lot of increase? There is going to be an increase in old age population because not much of war. I think we may have to promote more wars for all the people to die sooner. Alternatively, you are doomed to live long because medicine is advancing. You are cursed to live till 90 years old. Whether you like it or not, you have to live 90 years. And access to good health care. Most often, especially the people where the children are in the US or UK and only the father and mother are there, the minute they come, they will come back with a lot of sweets and some few electronic gadgets, and then they will bring that particular patient to your clinic. Sir, kindly do whatever has to be done for my mother or my father. In the sense, they have the money, they have the inclination, but there is no other way to show their love, to hide their guilt. They are not living with the parents. They are outside. They are not able to do anything. Just to hide the guilt, they bring them to our clinics, and then we have to do all the work, whether the patient requires or not, whether the patient needs or not. We have to do all these things. This is another reason why the people are living longer. Decline in fertility notes. Once upon a time, there were at least, my house, when I was, we are 3 at the home, and then in my generation, I had only 1, and then the next generation, my daughter and they were hesitating to have a children. So obviously, like in Tamil, இரண்டுக்கு மேல் வேண்டாம், then இப்போ நாமே இருவர் நமக்கு ஏன் இன்னொருவர். That is the kind of thinking, they don't want to produce any children. And obviously the older population will grow. In 20, as I told you, the younger population will be less than the older population. And life expectancy, as I told you already, it is slowly increasing from what it was. That's the reason why in olden days when my father, he retired at the age of 55, because they expected him to die at 60. So it is not the case now. You have to live for a longer, and even this year has got your retirement age is about 65. So the current life expectancy in India is about 72. There are 2 things to work on this. You have life expectancy and healthy life expectancy. The most important thing is healthy life expectancy. In the sense, at 78, I don't want few people to carry me. I don't want somebody to push me on a wheelchair. I don't want somebody else to come and brush my teeth. I don't want someone to lace my shoes. So I must be healthy enough to do all my work myself. All the work myself, even at the age of 80. So how do you classify old people? This is a very classical, very fit. We are not bothered about these guys. These guys are cursed to our society because they'll be running around half the time. We old people will be cursing, oh my God, this guy is running so much. I'm not able to do anything. I'm not even able to climb down the stairs. This guy is running a marathon. So this is the kind of people like our health minister, Dr. Ma Subramaniam. He does a lot of, he's almost about 70, yeah? You can imagine he's 70 years old and he has got almost about 21 full marathon over a period of time. That's fantastic. Oh, very well kept, managing well. Vulnerable, mildly frail is the case that you start declining. Moderately frail, severely frail, very severely frail, and terminally ill. These are the patients that we are talking about. So when you talk about India, India comes to about 109th place, somewhere in 109th place, and the population of the elderly people is slowly increasing. In 2050, it is going to be almost 85 life expectancy. It's going to be very, very difficult. Imagine you, everywhere you go, see you old people, oh my God, you will never be able to relish that. It's not going to be fine, right? So blatant reality is aging population is inevitably increasing. Aging affects all countries worldwide, and it is enduring and very, very progressive. This is what we are. Why? Yeah, can someone help me on this? Cursor kanabirchi. Quit. All right? Oh yeah. This is what we want. We want to live longer but not grow old. அப்படியே மார்க்கண்டைன் மாதிரி 16 வயசுல இருக்கணும்னா how is it possible? It is not possible. The universal law is you have to become old, you have to get disease, and death is absolutely inevitable. What we need is a very graceful death. That's all, nothing beyond that. So elderly adults are either functionally dependent older adults, frail older adults, functionally dependent. Very worse situations. And where do they live? Functionally dependent communities. That's like there are a lot of things in Coimbatore and Erode and all those places. And functionally dependent living in institutions, living with children, old age home, gated communities. Very limited organized specialized centers are available here in India. We don't have organized centers like in UK or in the US. I don't know about US, but in UK I'm very sure you have organized government run old age homes where the people who are dementic, who suffer from Alzheimer's, who are not qualified to live alone will be shifted to that particular home. And the property, their house or whatever the property they have will be taken over by the government, sold and be used for maintaining these people. It's not given free and it is pretty expensive, almost about 6,000 pounds a month. I know because my aunt and my uncle, both of them were in that particular old age home or that care houses. And the care houses will be very spick and span and will be very, very highly sophisticated. And we don't have anything organized here in India. The important concern is the systemic diseases, polypharmacy. How many of you know when you see an elderly patient of 70 years, they always carry about 6 to 7 tablets a day. A minimum of, even I take about 4 or 5 a day. So easily about down the line, another about 10 years time, I'll be at least about taking 10 tablets. So polypharmacy is a very, very major expense as well as deterioration on the system as such. Poor nutrition, its effect on oral cavity and oral health has a direct impact on aging. We'll talk a little about the oral manifestations. Cognitive function impairment. What is cognitive? You cannot just get up and then go up to the bathroom and then do your job and come back. You need assistance. You can't go to your dining hall, take your plate and eat. You cannot take the food and then eat. Somebody has to feed you. All these things are normal cognitive function. It can be physical, it can be mental, it can be musculoskeletal also. Approximately there will be 1% decline right from about 35-40 years and it deteriorates as you age. So theoretically speaking, by the time you hit 70, almost about 1/3 your cognitive function is legitimately you can lose, there's no problem. How does poor oral health impact general health? Oral health in elderly, usually compromised primarily because they are not able to brush their teeth. There is caries, there is periodontal disease, and obviously there will be an increased amount of oral microbiota that is going to reduce the opportunity to eat along with the pain. So the best thing is they normally avoid food, and obviously there will be a nutritional deficiency. So poor oral health. What is dysphagia? Any idea what is dysphagia? Difficulty in swallowing. Have you ever come across any patients saying, I'm not able to swallow? Normally people with about 75, 80, they have difficulty, but they don't know. I will show you a video if it is going to work, how difficult it is to have what's called dysphagia. So poor mastication, poor periodontium, carious teeth, edentulous state, pain, all leading to poor intake of food. It's just a vicious circle. You're not able to eat and you have a very poor health, and your poor health, you're not able to brush properly, and this goes on and goes on, deterioration increases. It not only stops with that, it also decreases your body balance. That means you're not able to walk straight. Suddenly you are going to have a fall and fracture, and your mental sharpness also goes, because just because you're old, you're not being very much wanted in a crowd. Right? Previously, when my daughter got married, she used to call me whenever they are going. I said, I also go sometimes with them for dinner, with his friends and things like that. But off late, they are not including me in that. Even if you feel that, even for a game of golf or even for a game of pickleball, I am not included, only that particular. So what you feel is you are being not neglected. You are not wanted there because you don't belong to their age group. You don't want to act 16. There is no need at all. So what happens? I'm very sportive, so I smile and go away. But I don't want to take it into your mind. The minute you take that into your mind, you go for depression. Depression is the first ever stage of Alzheimer's. So your brain activity comes down, your depression, you're alone, and then slowly dementia starts in, which is leading to Alzheimer's. Have you ever seen a patient who's suffering from Alzheimer's? Very difficult, very difficult. My aunt lost from her home. She lost herself in the home, so we have to fix up, complain to the police and find her out. It is not at all, situation is not at all favorable. And you go and say, I am so and so. I call mommy, Ravi Vandirka, I have come. That's it. You feel like crying. It's a very sad situation. But anyway, if you have to go through, you have to go through. The next thing is neglect from relative and friend and death of spouse, especially for men. Wife dies, the man is going to really suffer. It's going to suffer. It's a universal role. Maybe till the time you are about 30, 40, you will be cursing your wife. It's okay, fine. But you realize the importance of wife, at least the men, at least me, when you hit 60, right? Fine. Most importantly, you don't have much of money and poor intake of food, all these things. So what is the etiology of most oral manifestation can be attributed to xerostomia. Xerostomia, reduced salivary flow, is a general normal situation. Everybody goes through that. And another major important thing is a polypharmacy. Take so many drugs. Polypharmacy itself is a topic to discuss because each drug has got an effect on salivary flow, and what is the effect of the salivary flow on the oral cavity, you know that very well. Poor nutrition and poor water intake also contributes to major extent. So all this will lead to edentulism. Edentulism can be either total or partial, and both affects your masticatory efficiency. So lots of studies, even in India, these are all Indian studies, they are not international studies, Indian studies. It says, findings of these studies clearly demonstrate a high unset need for prosthetic care. So if you're going to see worldwide, most of the geriatric dentists are prosthodontists. They convert themselves into geriatric dentists because geriatric dentistry almost is synonymous with edentulism. Because major disease in elderly people is only partial or total edentulism. I'll give you statistics. Stage 1 of oral aging. Decreased sociability and daily activity. Decline in oral healthcare literacy. Decreased motivation. Setting in of tooth and periodontal disease. Setting in of general and social frailty. What is general and social frailty? You have to know. This is ADL, activities of daily living. These things will be decreased. So you sit in a couch and then watch TV, and then you suddenly feel thirsty. What will you do? Your granddaughter will be, hey, Kamala, and the tanya today. You know, you don't want to get up, go up to the water and drink. So you ask somebody else. So the daily routine is going to be absolutely going to be reduced. Instrumental activities of daily living, like cooking, all these things will be reduced because you feel not lazy, don't have the motivation to do this. So you have yardsticks for all these things for men and women, and you will be able to say whether the patient is going in for a general frailty or not. Social frailty is described as losing or having lost social and general resources, activities, or abilities that are important for filling basic social. In the sense, you don't go to marriages. All those things are very, very, like typical of social frailty. You don't want to go meet people. Why should I go and meet him? There is no need. So all these things are very classical signs of social frailty. And this kills. This really kills. Hey, don't worry guys, I will be giving you this presentation, no problem at all. I will give it to Dr. John, Professor John, and then you can collect it from him, no problem at all. Absolutely. So depression is the first ever thing. Depression is the first ever thing. Depression is not a normal part of aging, but more people get depressed. Why so? Why so? Why is that they are getting? Because there is reduction in your regular strength activities. You can't even walk comfortably. And most importantly, you are losing importance at house. You are losing importance at house. Most of the decisions the children take are without the knowledge of the elders, and number 2 is they are being informed. When they were small, they come to us and ask, Appa, can I do this? Now they said, Appa, I've done this, am I right? And after some time they'll say, I've done it, Pa, that's all, don't worry. So this is the kind. So what happens if I'm old, if my thinking is old, I'll get depressed. I don't want to go through this, right? Accumulated consequences of bad choices, all these things are part of all these things. Most important thing is loneliness, especially when the spouse dies. And avenues of money is very limited. At the end of the day, you're not making any money. You have to deplete your resources. All your fixed deposits will go slowly come down. And like, it is tough to make ends meet. So, what are the factors? Gender. Men are more susceptible to depressions. Women are extremely flexible. They can survive anywhere. Men are very rigid. Educational status. Caste, especially in Indian context, it doesn't work in the international this thing. Caste does play a very major role, and economical status. And physical fitness, comorbidities, polypharmacy, cognitive health, and depression, as I told you already, these are the things which are self-inflicted. The minute you are alone, you will always think, oh, why is it this fellow has not told me? Why is it he is doing? So you start thinking unwanted things. Loneliness really kills. Decision-making participation on gift to children and grandchildren. He will not keep quiet. He wants to involve himself in all the decision of the next generation, which is not his job. You have to get mentally prepared to involve yourself only when required. So problem of aging in India, changing family realities, young Indians are going abroad, greater investment by patient, both financially and emotionally, all these things. That's the reason why, our Talibar says, you have to know where to stop. At the end of one particular stage, you have to cut. You don't have to have attachment. You have to have detached attachments. You are there, I am there, we are happy on each other's this thing, that's all. Problem of aging, India does not have a robust social security system. Infrastructure is not for elderly or disabledly friendly. Job avenues are red at the end of this. After 60 years or after 65 years, I cannot apply for a job. It is not possible. I can only go for a I have done my post-graduation. I will not go as a watchman. I cannot go as a Swiggy delivery boy. I cannot really do that. Can you give me a desktop job? It is not possible. So there is no avenue at all for the elderly people. So how to avoid social frailty? Have friends. Most important thing is have friends. You always have like-minded. So that's also a very, very positive way of thinking, because what the problem you have, even he has. So collectively we can sit together and talk. And most often, now that you are a technique, savvy a little bit, you can go into get involved yourself in Instagrams, WhatsApp, and then do all sorts of things. And play outdoor games, sports, yoga, all these things are there. Eat out at the restaurants and attend religious functions. But the most important thing is this. You need money for all these things. If you have limited resources, so you cannot go to restaurant, you cannot go to the club, you cannot do anything because club charges you at least about 67,000 rupees a month. You must have enough money. So gentlemen, ladies, start working, pull up your sleeves and then start working for the last days. So stage 1, normally patient presents like this, they have poor oral hygiene. So this is the condition. I'll just skip through this because it's a conventional. Treatment wise, nothing changes much. In my practice, when an elderly patient comes, 70 plus comes, I don't do all my best to that particular patient. What is required, I do. So this is the occlusal surface. I do a conventional fixed prosthesis. Though the patient could afford implants, though the patient was willing for implants, I was not very keen about putting him through surgical this thing. I gave a shortened dental arch and then fixed the whole thing. Stage 2, oral frailty. Oral frailty is a very, very important terminology I want you to understand. And this is a concept which has been put forward by the Japanese Dental Association because Japan has the maximum number of old age people. There's one village, one island called Okinawa. It's in down south. below Kyushu, below Fukuoka, there's an island called Okinawa. Okinawa produces what? The maximum number of sumo wrestlers. Sumo wrestlers are all from Okinawa, and they have the maximum number of old age people. And you must go and visit that particular place. So very encouraging. All the people in the house are plus 90, and exceptionally very happy about living there. So only they formulated the definition for this. The instruments are one, how will you classify that he is suffering from? There are very many ways of doing it, and Kihon is one of the ways by which you will be able to do this. And the most important of all this checklist is reduce number of teeth. Edentulism. Edentulism is the most important yardstick. How to investigate oral hygiene, all these things, the number of CFU is, or any oral pathologist will help me, I just forgot, units, and C is colony, sorry, prosthodontist, dementia, everything is here. All right, fine. Colony forming units. All right, fine, good. Oral dryness, biting force. No, you have never ever thought of biting force as an important function. You have never thought of tongue pressure as an important function. And you have never thought, I've never thought of dysphagia. Will I ever suffer dysphagia, difficulty in swallowing? I have never thought of all these things. Off late, I'm thinking about all these things. So oral frailty actually has a multidimensional and multisystemic nature, a marked susceptibility to a cluster of adverse health related events, less education and low socioeconomic also. Fine. So this is a patient. What will you do? What will you do this for this patient? So what I suggested, as usual, like you guys who are in the 15, 16s or early 30s, let's remove all the tooth, go for 6 implants, so that, like I can go to the club for the next about 5 more years time. I can socialize, I can play golf, I can do whatever I want. So I was planning for this. Then somebody hit me on the face and said, okay, do dentistry, don't do anything called sales. So I came back to reality. I said, okay, I will preserve whatever is possible. And for the kind of eating that he does, we will give him a removable dentures. So this is what I planned, prepped all the teeth, and then gave him a temp. I gave him attachment retained removable partials, which is absolutely functional. Absolutely functional. This is how the removable denture function, and he is very happy with this. For the kind of food that, like he is eating, this is absolutely good. He is able to eat very well. So stage 3 is hypofunction. The very, very marginal difference between hypofunction and frailty. How will you differentiate between frailty and this thing, hyperfunction? Not much of differences, very, very marginal. All the factors of hyperfunction and frailty are there. Is hyperfunction or oral defect both the same? Yes, it is almost, but there is a small overlap. Because oral structural defect is anatomical, whereas you also have a psychological component onto this. So you call it either frailty or oral. So if you're going to differentiate oral hyperfunction, oral hygiene is much poorer. Oral moisture control, oral moisture is much more lower. Biting force is more. So it's only on a scale of 1 to 10. If it is 5, you call it frailty. If it is 3, you call it hypofunction. Though you don't have any particular yardstick. There are, yardsticks like your scores. You can use it, but not everything you will be able to do that. Swallowing is a very major difficulty in this particular group of people. They will not be able to swallow the food that they really want to. So what is swallowing? Has got oral preparatory phase, oral phase, pharyngeal phase, and esophageal. Is that fine? So what is that in the oral preparatory and oral phase? You put the food in the mouth. So what should happen normally? It should be propelled into the oropharynx, isn't it? So for that, what do you need? You need water. It has to be moist. So if the mouth is dry, it's going to be very difficult. You will never be able to push. What's number 2? The tongue pressure. The tongue pressure has to be good enough to hold it against the palate and then propel the food backwards. What is the third? The lip pressure. You should be able to control, have a closure. You can't keep the mouth open and swallow. Not possible at all. So you have to have a lip closure. That pressure is also important. I have never thought of all these things when I was studying. So esophageal is propelling back into the food. So oral prepared food is masticated, chewed mouth. Most often elderly do not know how much to take. So they don't know, especially if they are going to be dementing, they will not know how much to take. The minute they see the food, they are, just out of compulsion, they just keep pushing it in. They chew or they push in more than they can chew. They bite on more they can chew. So this leads to choking. Choking is aspiration. So we'll see, yeah, we have it here. So this is a normal epiglottis. You are able to see the epiglottis moving. That's it. So this will prevent the food either going into the windpipe or into the esophagus. Is that right? Right? Is that right? So whenever you're eating, this epiglottis will close the windpipe and then allows the food to go to the esophagus. So difficulty, this is what happens classically. This is what you see, he is able to, you see the food is right in the tongue only, it is not getting propelled into the throat. It is still there, like dancing right up there. He has got a partial, and then he is biting, he is chewing, he is trying to put the food into the throat, he is not able to. Very tragic situation. What will they do? They either will choke or they will spit it out. Very sad situation. So what happens next? Aspiration. This is not working. I'm so sorry. I'm so very sorry. This is a very interesting video where when he swallows, that when the esophageal stage comes, the epiglottis does not work completely. It opens up a little bit, resulting in the food. This is a cine videography, absolute cine radiography, where you will be able to assess the whole thing. This I have taken it from one of my Japanese friends who do a lot of research on dysphagia. So this is a very, very classical this thing. I'll try to attach this also in the next, when I give it to him. So in stage 4, there is oral dysfunction. Eating disorders, swallowing disorders, masticatory dementia sets in. These are most often seen in care homes. So these people, they do not live in the house. The children do not have the patience. Understandable. I did not have the patience to take care of my mother, who was very, very fine. So I was a little patient because at the age of 30, 35, I was concentrating on my career, I was concentrating on making money, and obviously all these things will go to the backseat. Dementia in elderly population is prevalent. It doubles every 5 years. 30% at 85, 90, and 50 at 94, and 70, 95 plus. So look at this patient. I hope this video at least works. No, this video also doesn't work. It's okay. So this is a dementic patient who suffers from Alzheimer's. I'm sorry, this video should be playing, but this is not playing. I don't know why. Okay, I'll go back. So you give him a denture. She doesn't know what to do with that. So she's literally playing with the upper and the lower dentures. And the caretaker has to tell him, you have to wear this and then eat. That is the kind of patient that we are talking about. Dementic patients, patients with Alzheimer's, these are the patients who are going to suffer a lot. And this is another patient, another video. He knows that this is a denture. Right? He knows this is a denture with which he is going to eat, but he has forgotten how to wear the dentures. Look at the way that he is holding the occlusive surface on me. It should have been the other way to push the denture in place. So this is the kind of patients, they mostly in the stage 4, and they are in the home. They are not in the houses. So if we're going to talk about the prevalence of oral condition, edentulum is the maximum thing. It is 45 to 70% of the patient are partially edentulous. And what if they are edentulous? Basically, they don't have occlusal contacts. What is the importance of occlusal contact? It is extremely important when you talk about the mixed dentition. The tooth erupts, makes a contact. So if you're going to take occlusion as this thing, it is an orchestra. You have multiple components. Unless all the players play the right note, you will never get the music. So what happens when you lose one tooth? When you lose one tooth, there is oral maxillofacial differentiation. This deafferentation, that is the nerve supply from the tooth to the brain, is going to be cut off, and that particular area is going to be vacant. Imagine you are going to lose more number of teeth. If you're going to use more number of teeth, the area of vacantness in the brain is going to be, there is a lot of technical this thing. I'll skip a little bit. I'll skip a little bit so that you will know what exactly happens. The masticatory process increases cortical blood flow also, correct. So all this, when you're going to have more number of loss of teeth, the area in the brain which is going to be vacant is going to be more. That is the beginning of depression, dementia, and Alzheimer's. And not only that, only if you have to have an occlusal contact, there will be increased blood flow, which is going to be healthy for the brain too, right? So edentulosum, people with 20 teeth show very favorable impact on quality of life. So if you have about 20 teeth, that is good enough. That is the basic, philosophy behind shortened arch. If you talk about shortened arch, why should you have 7, 6, and 7? Up to 5 is enough, because 5 is the right thing, or rather absolutely enough for a normal masticatory function. If diminished more lost teeth, 10 to 20, maybe less than 20 if it is going to be, less than 10 it is going to be there are going to be no occlusal contacts. That's going to reduce the blood flow to the brain, as well as you're going to become dementic, or you're going to succumb to depression much more faster. The mantra was that they were able to choose the food. How were we surviving? Up there they will take only the mixed food and things like that. I will finish another 5 minutes, madam. It's okay? Yes, okay, fine. All right. So edentulism, we will 20 teeth show a favorable quality of life. Okay, I'll skip this. Also, a lower intake of fruits, fibers, all these things increase. Fine. This also I will skip. So tooth loss and obstructive sleep apnea. So obviously there are a lot of research. Tooth loss and what are the other diseases. Sleep apnea is also one of the greatest. Sleep apnea, I don't want exactly tooth loss and sleep apnea is more because of the fact that there is no teeth. So what happens? Tongue goes back and then there is an apnea. I feel so, rather than this thing. Hearing impairment. See, recently there was one article, WhatsApp, in the paper also. After giving the implants, everything opened up and he became, oh, very good, I am able to hear. So that kind of, things do happen. It is not directly directly proportional to the occlusal contact, but there are studies. This is one of such studies. I also have a study and publication on that. Poor nutritional status will lead to exacerbation of chronic illness like cancer, hypertension, and heart diseases. Morbidity, you will die soon if you don't have teeth. So at least for that you better have teeth, or give an artificial occlusion. So the need to discuss aging and oral is very, very evident, and the need for geriatric specialty in India is very, very, very important. Thanks to IDA for coming out with a new fellowship where they are going to start with our association called Aged, a fellowship program on geriatric dentistry, where you will be given a fellowship by the supreme body of dental associations, namely the IDA. So I encourage all the youngsters to go in for that particular course also. We also have a specialty organization called Association of Geriatric Dentistry, which is very active. So evaluation criteria, I don't want to go in for greater details. It's not very important for you and I. It's only for the researchers. And in my opinion, there should be only one, so that the language that you and I will speak are going to be the same. How to render treatment? The aim of the treatment should be to reduce the rate of edentulism, tackle complex problems, and give them the best of the treatment for that particular age. And most important is to reduce the cost as much as possible. The percent of the dental wear over the period of time, right from 50 to 80, it increases to almost double. So edentulism and denture wear, there seems to be an universal acceptance of the results shown below. So what is that? Removable process was well accepted. Difficulty with partials are more because of food stagnation and concomitant oral hygiene measures, and CD patient showed good improvement in the quality of life. So you give them a denture. It is very important. You give a good set of upper and lower removable dentures. Even that is absolutely good. It is well documented. I have already said about this. The results suggest that chewing may accelerate or recover the process of working memory, besides inducing improvement in the arousal of levels of chewing motion. So all these things will collectively improve the activities of the brain, and there is a bright possibility of reversal of your depression, your dementia. Alzheimer's once sets in, it is not going to be that easy. In a private study in our university, subjective and objective evaluation of oral quality of life and complete dentures, the results are extremely encouraging. About 1/3 improvement in masticatory performance was achieved with conventional. So even if you're going to give a good, nice, removable dentures, it is absolutely good enough. Fine. So this is another study, not by us, but somebody else. The presence of an established occlusal vertical dimension has influence not only on static balance, that means the patients do not fall. If you don't have the teeth, there is a bright possibility that may lose the balance and fall and then fracture, but that is not going to be there if there is going to be an occlusal. There is a documented evidence by a case done by one Dr. Madhusudan in Government Dental College, long back, especially Parkinsonism. The patient is Parkinson's. The minute you put the dentures, he becomes absolutely all right. We don't know the scientific basis, but anyway, occlusal contact seems to be the mantra for all these things. So the conclusion is significant improvement of pre-existing hearing impairment has also been reduced. So the idea is to give a full denture, which is removable. The important thing is that you give an occlusal contact. You give a removable partials, no problem. You give a removable dentures. Absolutely retain the rest of the teeth and then give them a novo denture. Whatever that you want, restore the occlusal contact. The minute you restore the occlusal contact, most of the diseases, especially related to old age, come back to normal, almost to normal. And oral general health related quality of life with conventional implant dentures. What does this McGill consensus says? You have 2 implants. It's supposed to be one of the best. This is a universally accepted this thing, and it has been practiced for more than about 4 or 5 decades. And this is what the McGill consensus says. So what is our responsibility? So our responsibility is to reduce the cost. Can our population afford 2 implants over dentures? That's going to cost a lot of money for them. Really, especially for the retired persons. Considering that minimum, it's going to cost about 25,000 rupees for it. So 50 for 4 implants. So if there is an avenue for you to reduce, that will be the best thing. So my proposition, not my proposition, the proposition from the prosthodontic world is to reduce the number of implants and then go for a single implant. A single implant protocol is absolutely fine. We have done a lot of study on this also. One central incisor right in the middle, in the symphysis area, mandibular dentures, implant, and it works absolutely fine. My study, which has been published, and there is an improvement of quality of life, and body balance has also improved. That has also been published. And I also have masticated performance, crestal bone loss. If we're going to say, if we're going to keep only one implant, there will be a huge crestal loss. All these things are rubbish. You can just dump them in the dustbin. This works absolutely fine. These are all documented evidences, and that too in COIR. So I have enough and more of evidence to say that by just giving a single implant right at the incisors, especially for the elderly patients, you will be able to improve the quality of life. So in conclusion, single implant supported magnet or overdentures significantly improved oral health related quality of life of completely edentulous patients. So this is another study of body balance. Even our study concurs with the same. Improves the amount of fall is going to be reduced to a large extent. So treatment protocol, especially for elderlies, is definitely increasing. You have to essentially be equipped for that. Oral hygiene care for this segment is becoming more apparent. General evaluation should be a part of dental treatment, and preventive measures should be to be planned and reduce the incidence of edentulism. Alternative effective treatment plans should be thought of. Curriculum should include geriatric dentistry. None of other books have got geriatric dentistry. We should have a paper on geriatric dentistry. At least in prosthetics, you must have a chapter. So that could be the reason why in our book we have introduced this particular topic, geriatric dentistry, as one of the topics. So kindly go through this particular topic. You didn't have to go through the book. If at all you want, I'll send you the PDF. And we must also have specialized associations. I urge the senior members of the profession to join. And along with this, if there is going to be additional diseases like Parkinsonism, like this is supposed to be a video. Unfortunately, it is not playing. You must, in the Western countries, my close associate, my postgraduate and my undergraduate student, one Dr. Murli, is the head of geriatric dentistry in Zurich. They succumb all the students to go through this particular test. This is a test where there will be multiple electrodes, and the minute you switch it on, there will be short electrical waves which will give you a simulation of Parkinsonisms. So they are supposed to read the paper, they are supposed to count the money. Every time there is an electric shock, they will just jump, and it isn't going to be in a periodic this thing. So simulation of this situation, what an elderly person goes through, has to be given to these youngsters also, so that they realize what exactly is this. So the role of specialist association like IDA and AGD is going to be a very specific treatment protocol. I mean, if you're going to talk about root canal treatments, or if you're going to talk about periodontal, if you're going to talk about the application of this, what is it called, some silver diamine fluoride and all those things, are almost the same. There is no big treatment change, but you must know only where to limit. The most important thing we are trying from an association to inform the government is that you have a campaign called 70-20. At the age of 70, at least 20 original teeth must be maintained. In Japan, they have 80-20. At 80, they are insisting that they must have at least about 20 teeth. So subsidy for 70, all the people like in your NHS UK, you have to have at least about 20 patients a month, or for which you have to do a subsidiary treatment. So if that is going to be a government rule, I think the general elderly population will get benefited. So we are treating him now. He is heading it here, right? And the question is, are we ready for him? But I will tell you the best way to avoid old age. What is it? The best way to avoid old age is this. Take a lot of diazepam, go on a highway and doze off. Thank you very much for a very patient listening. I hope it meant some sense to you. Thank you very much. In the absence of questions.
Thank you, Dr. Padmanabhan. It was a wonderful insight on your long-term perspective of aging and how to improve the oral health quality of life as you go for a geriatric stage. So it was a wonderful lecture. We can take few questions if you have any questions related to this keynote address. If it is allowed, we can take few questions. Okay, I suppose all are well aware of the geriatric dentistry.
Age is a number or mind, all these things is okay for conversation. It's all a number, all these things is only a conversation. By and large, if you're going to see, only about say 0.5 or 0.6% of the old age people who are 70 are able to run. Very sadly, I was running about 3 years back. I'm not able to run. I feel very sad about it. That was the reason why I took up geriatric dentistry very, very seriously. I am not able to run. I feel very sad. I'm not able to play. I have taken up pickleball now. I'm not able to play pickleball. 2 days I have to pop in medicines. I do a very, very, very strong exercises. I mean, despite all these things, aging is genetic also. You age early. It is genetic also. You just can't be saying it is all in mind. I don't want to believe it. To some extent, it is in mind. How long will you keep yourself sharp? People say that you play Wordle, you play this, what is that, crossword. You play, there is one more in mathematics. I don't know what it is. So you play all these things, you will keep your... So I really want to... Yes, Madam Ji. Yes, Madam Ji.
Yeah, there is a question.
Yep.
Go ahead.
Hello everyone. It's not a question. Actually, we should prepare to age by 30. We are not to start changing the things by 50. After you age, if you want to prepare for aging, not possible. So maybe by 25, 30, you should prepare for retiring and be healthy. So it's actually to be given to youngsters so that how to live happily during aging. Thank you so much.
Correct, I think so. I totally agree with madam. The first thing is that at 30, 35, make a lot of money, yeah? Like a lot of money. Money really is going to be very, very important during your old age. Absolutely. Madam Ji, please.
Hi, good morning. I'm Dr. Vinita from Delhi. I would definitely like to say that what you're talking of is something the students of today will not understand the importance, but later, as soon as they get into practice, they will understand what all you've said and how meaningful it is. Okay, my question is actually related to implants in, over 70, 75-year-old patients, and sometimes we end up giving them all-on-4 fixed prosthesis for the upper. I just want to know, is there a correlation between the patient's ability to maintain the hygiene of that prosthesis and development of any serious illness like cancers or any other systems, which is there any study or is there any thing that you've noticed in any of the patients? Because I came across one of my patients who was really poor in her oral healthy maintenance of the mouth, and I kept telling her that this is not okay, I'll have to remove your prosthesis, but she just vanished, and then she came with oral carcinoma. So I just want to know that have you come across any such incidences?
There should be, but I don't know about the published literatures. But when you talk about a patient who suffers cancers and who is undergoing treatment, Madam Ji, Madam, please be seated. Tasrif rakhiye, please. So, a patient who's undergoing cancer treatment has got no inclination for his teeth. Absolutely. If it is going to be oral cancer, resection, maxillectomy, mandibulectomy, and especially post-resection radiation, the hygiene is going to be really reduced because of trismus. They are not able to access, and basically they are very lethargic. Very few patients are enthusiastic about this thing. And when you have any systemic carcinomas, and when they are on chemotherapy, it has got a very poor effect on, very, very strong effect on the oral cavity. The first and most important thing is xerostomia. They have reduced salivary flow. The minute there is reduced salivary flow, that particular candidate is not intended or indicated for implant therapy. So the minute you know that this is not going to be, I would prefer not to go in for an implant therapy, but this is, you have given me an initiative to search for that particular article. The minute I'll get it, I'll send it across to you, madam, because I've also not thought about this. This is an excellent brain draining session for me also. You're able to give me a suggestion, so that I'll work on that also, because I have not treated any of the patients. People who have recovered, especially women after breast cancer, resections, I was able to do all these things, but the people who have gone through chemotherapy, who have come back almost to a normal salivary flow, we are able to work. But during active treatment, where I'm able to see a perceivable reduction in the salivary flow, I normally don't take up. And they are also not inclined, madam. They would have spent tons of money, but for this, at least for the moneyed people, if you are, will you be able to give? I have not thought of it yet, because I have not come across such situation. Thank you for this information. I will work on it.
Thank you. I think there are no further questions. Yeah. Thank you so much.
Thank you, sir. Thank you very much.
Professor Padmanabhan, for giving a wonderful insight.
Thank you.
Thank you so much.
Thank you.
Thank you, sir, for the thought-provoking and enriching session. I request our Dean, Professor Dr. J. Babyjohn, sir, to give the certificate to Dr. K. Ramesh, sir, for chairing the first keynote lecture. Now we have a short 15 minutes break, moving to the second lecture. Kindly be back within the stipulated time. The refreshments are served outside the hall. Thank you.
Hello, check. Check, check. Check, check.
Supercalifragilisticexpialidocious.